occasion, his wife gave him a really awful tie to give to me and said he won't wear it, and I did. And we have photographs of that. Felix, thank you very much for this invitation. When Felix asked me to talk about secondary pulmonary stenosis after arterial switch operation, I rang him up and said, what is it that you want me to talk about? And he said, secondary pulmonary stenosis, so that wasn't very helpful. So then I thought, well, I better look at the results in the literature of what causes secondary pulmonary stenosis, if indeed it's a big problem or not. And one of the papers last year from Leiden Group reported on the outcomes after the arterial switch operation on 332 consecutive patients, of which just over 200 had intact ventricular septum. And the hospital mortality in that group was 11%, and the overall survival at 15 years was 85%. More importantly, freedom from reoperation was 74%, and of those patients who had reoperation, 28 out of the 52 required reoperation for right ventricular outflow tract obstruction, and so overall this was 9% of the population. There were other problems such as moderate or severe aortic regurgitation, but I wasn't going to focus on that. So then I looked at our own Evelina Children's Hospital experience since 2000, largely because the database was reliable from 2000 onwards. Prior to that, it was a fairly rubbish database and it was inaccurate. And so from 2000 to last year, we've done 233 arterial switch operations, of which 149 were isolated arterial switches. The other interesting thing was that we were discussing this morning was the atrial septostomy, and only 50% of our patients required or had atrial septostomy performed. And the point I was alluding to was that if the surgeons say they're going to do an arterial switch on this patient on a Monday and the baby presents on a Friday, we don't do a switch. So it's very much determined to some extent by the timing of the operation and when the arterial switch operation could be done. And the results are not bad. 30-day survival, 96%, 1-year survival, 95.5%. But there were only 6% of the patients that needed another intervention. Just to show that the national outcomes for the whole of the UK, the mortality is around 1.4% in the last year, hovering around the 2% mark. And Evelina is fairly similar, apart from this blip. That's 1 death out of around 10 patients. Now, of those that needed another intervention, pulmonary artery intervention in this group of patients was needed in only 1.7% of patients. So, and those were 3 who had surgical repair of the pulmonary artery obstruction, 1 who had balloon dilation of left pulmonary artery, and 1 who had stent in right pulmonary artery. And I thought, I can't spend half an hour talking about 2 patients. So I had to rely on friends around the world to give me some examples, and so fortunately I found some. So what causes secondary pulmonary arterial stenosis? Well, it's always easy to blame the surgeons. It's the anastomosis. It's always easy to blame the surgeons. It's stretching of the pulmonary arteries after the Lecomte maneuver. It's the patches that the surgeons insert. But there's also a possibility of external compression, as we were discussing again before lunch, that the aorta may compress on either the left pulmonary artery or the right, more usually the left. We've looked at some MRI scans in our patients, and this is an example of a 17-year-old patient who's completely asymptomatic, had an MRI scan before being transferred to the adult service. And what you notice is that the right pulmonary artery is flattened, but otherwise the pulmonary artery anatomy is excellent, and this would be classified as an excellent long-term result. But there are other situations or problems that can occur. You can see here very mild to moderate supravalvular pulmonary stenosis, and this has to be related to a combination of anastomosis, patch, stretch, the whole lot of those factors that we mentioned. Here's another patient, and I can't remember, I think this may have been from Lee Benson because I was really struggling to find things. Here we've got a patient who has right pulmonary artery stenosis as well as left pulmonary artery stenosis. Perhaps the left is more severe than the right. Here you see the left pulmonary artery stenosis. This has to be a stretch effect from an anteriorly placed pulmonary artery. with a patch, combination of the patch that has perhaps shrunk a little bit and the arteries that have stretched. Here's another 3D reconstruction of the MRI and black blood images showing this long segment stenosis of the left pulmonary artery. Here it is again. And you see the aorta. It's difficult to imagine that this is from compression of the aorta. It's more likely to be the combination of stretch and a patch. This is not a surgical talk, but Ullmann, I don't know if he's here, but from Heidelberg, reported on a sort of surgical technique to prevent pulmonary arterial stenosis after the switch maneuver. So the surgical technique included Lecomte maneuver combined with an extended autologous pericardial patch with augmentation of the posterior pulmonary artery wall, and that was a good way of reducing the incidence of pulmonary arterial stenosis. Nothing new about that, but there are some techniques in the literature which involve inserting this patch in glutaraldehyde, and some without the use of glutaraldehyde, and the incidence of stenosis in the literature doesn't seem to vary all that much. So perhaps it's combination of surgical technique as well as the patch as well as the stretch. From Ullmann's series reported 5 years ago, there were 58 patients they evaluated with Doppler. None of them needed reintervention, although 74% of the patients had gradients by Doppler, and this is usually overestimated, of less than 25 millimeters of mercury, and others had a gradient of more than 25 millimeters of mercury. Here's one patient who had a gradient less than 75, but certainly classified as moderate. So perhaps emphasizing the point that the surgical technique has a large part to play. When pulmonary arterial obstructions occur after the arterial switch procedure, how do we deal with them? Well, the options are obviously to use balloon dilation. That's the oldest technique that we know about. Should we use or think about using cutting balloons? And when you know the reasons for the obstruction, then you probably say no. And should we use stent implantation? Well, cutting balloon works in this way. There is a balloon with blades distributed around, I'm just trying to get this to work, distributed around the circumference of the balloon. And once the balloon's inflated, the blades cut or score along the vessel wall. Well, that's all right with some of these unusual anatomies of peripheral pulmonary arterial stenoses. You can use cutting balloons because the intimal wall is thick. But when the pulmonary artery stenosis is in relation to stretch or external compression from the aorta, then it would be completely inappropriate to be considering using cutting balloons. What about balloon dilation? Well, from the literature, the balloon dilation of branch pulmonary arteries, not arterial switch ones, but the general results vary. They vary from 38% success to 72% success, and the lower success rate is with low pressure balloons and the higher success rate with high pressure balloons. But there are complications in relation to pulmonary artery balloon dilation. They occur in about 6 to 18%, mortality up to 2 to 2.8%. Pulmonary arterial trauma, dissections, up to 2%. Aneurysm formation, up to 4%. Transient pulmonary edema may occur in up to 14%. And restenosis, a variable but high incidence, 0 to 35%. So is balloon angioplasty a good technique in arterial switch-related pulmonary arterial stenoses? Here you see an arterial switch operation in a patient with left pulmonary artery stenosis. And here in the middle picture, a high-pressure balloon has been used. And that, when it works, you'll see the indentation disappearing. And then here's the angiographic appearance afterwards. And you'll see it's not a very good top-quality angio, but you'll see that there is some difference made by high-pressure balloon. The vessel is certainly more widely open. Nakanishi's group from Tokyo published about 8 years ago now results of balloon dilation for pulmonary arterial stenoses. And their indications were a right ventricular pressure of more than 2/3 systemic, significant stenoses on angiograms, pressure gradients at catheter of more than 20 millimeters of mercury, reduced flow on perfusion scans to the affected segment, and ballooning, they used a balloon to stenosis ratio for the branches of the pulmonary artery of 3.5, but when the stenosis was in the main pulmonary artery just above the pulmonary valve, then the ratio was 2.5. And then they used predominantly low pressure balloons, but high pressure balloons were occasionally required as well. The problem with balloon angioplasty or interventional technique is definition of acute success. Their definition was that there was a 50% increase of the diameter of the stenotic lesion on angiography, and we can all work that out and move around the numbers and suddenly define a successful outcome. And the clinical success was defined as a reduction in the ratio of the right ventricle to aortic systolic pressure to less than 0.65 immediately after balloon dilation. And then during the follow-up, that ratio remained at less than 0.65. 87 patients had 137 balloon dilations on these pulmonary arteries. So important to note that balloon angioplasty of these arteries is not a single procedure. Many patients require repeat dilations in order to achieve some sort of long-lasting result. All of them had had Lecomte maneuver. 37 patients had 52 procedures on pulmonary arteries, and these are patients that they then restudied. So it's not the whole population that had repeat cardiac catheterization, but these had a study, cardiac catheter study, at a median of 4.3 years. And 12% of these developed restenosis. But there was an increase in the vessel diameter and a reduction in the gradient across these stenosis that was sustained. Those 52 procedures or 52 lesions rather, 40 of those 52 lesions were at the origins of the branch pulmonary arteries, 18 in the right and 22 in the left, and balloon dilation was successful in 58% of these. And there were 12 lesions that were supravalvular pulmonary artery stenosis, so in the main pulmonary artery. Ballooning was less successful in these, in only 25% was it successful. And in patients who had repeat catheter studies, 68% of them had a sustained right ventricular aortic pressure ratio of less than 0.65, and 4 patients had a higher pressure than this. All of these were supravalvular pulmonary stenosis. So that's one area that you can identify as not being suitable for balloon dilation. Here's an angiogram from one of their patients that was published. Bilateral branch pulmonary artery stenosis immediately after balloon dilation of both the lesions, good result. Follow-up angiogram 5 years later, good result as well. And the same in the larger population. You see here that the stenotic diameter is maintained, or there is some evidence of growth during follow-up. And in the other control group, the stenotic diameter increase is sustained as well. In their patient population, there was a patient who had left pulmonary artery stenosis, which was thought to be compressed by the dilated aortic root. And acutely, the result was good. 6 years later, the stenosis is as bad, if not worse, than before. So we have to be cautious about the mechanism for the stenosis as to what will happen with the long-term result. 3 out of 26 vessels re-stenosed, and all 3 were left pulmonary arteries. 1 of these was compression by the dilated aortic root. They were unable to say what actually predicted the recurrence of re-stenosis. So pulmonary artery stenosis is the commonest complication after the arterial switch operation that requires intervention. There are other complications which we just keep an eye on. The incidence of pulmonary arterial stenosis, depending on the reports, varies between 1% and 42%. The need for re-intervention varies between 1% and 30%. Mechanism that I've mentioned is thought to be scarring, distortion and stretch, and compression of the left pulmonary artery by dilated aorta. Balloon dilation is successful in about 50% of patients, and stents possibly may improve the results more predictably, but the results of stents are not really large numbers. There's a variety of stents. We've all seen different types of stents that have been used for these lesions. The closed cell Palmer's genesis or premounted genesis or Palmer's genesis, the open cell intrastent, and some of the bare stent CPs or covered CP stents as well. The problem with stents is that they do not grow with age, and therefore they will need redilation as the patient or the child grows. There is neointimal proliferation possibility, and that may be an issue. And stents are best to avoid in infancy and reserved for older children or those in whom balloon dilation has failed. So we tend to go for balloon angioplasty even if it's likely to be repeated in the first few years of life, and when the child is older enough to have a stent implanted that can then be redilated to an adult size, then that patient would be suitable for stent implantation. Here's one of the patients that I collected who has main pulmonary artery or supravalvular pulmonary artery stenosis after the switch operation, and high pressure balloon was used in this example. There you see the high pressure balloon being inflated across it, and there you see the angiogram result immediately afterwards, and you'll all agree with me that it doesn't look any different from that angiogram. If you are optimistic, you might say there's a couple of millimeters increase in size, but otherwise no significant difference. Here's another patient who has fairly similar problem, and in this patient, this was from Warsaw. I'm grateful to Grażyna Brzezinska for the pictures here. And you see here in this patient that supravalvular stenosis was dealt with by a stent implantation in an attempt also to dilate the supravalvular stenosis, but also to try and avoid the pulmonary valve. And you see here that the stent has redilated or dilated that supravalvular stenosis, but one of the leaflets of the pulmonary valve is probably trapped in that stent. Nevertheless, the supravalvular stenosis was dealt with by that method. Here's a right pulmonary artery stenosis after an arterial switch operation, in whom a Parma's stent was implanted, and you see here the stent in position, if that plays. It was playing earlier on. I'll go on. Here's a slightly more complex stretch of the branch pulmonary artery. You see here a very long segment of pulmonary artery, and in this patient a premounted genesis was used, and that covered the proximal portion of the pulmonary artery stenosis, but there was still an uncovered portion, and you see here the angiogram immediately after that proximal stent was deployed, and then this was followed up by a second premounted genesis stent. You'll see here being inflated, and then the proximal stent was redilated in order to stretch it a little bit more, and here's the angiographic appearance afterward. Again, not a very good angiogram, but it shows that the lesion has been stretched up. Now, the problem with premounted genesis stents is that they have a limit to the expansibility, the diameter that you can achieve ultimately, and therefore whatever stent is used, you need to be sure that it can be dilated up to the adult size. If it cannot, then it's a problem that is created or deferred till the teenage years, when possibly more surgery may well be required to remove that stent, and more extensive surgery may be required. Here's a patient with a left pulmonary artery stenosis, and this is an educational one. This patient had a Parma's stent implanted, and here's the angiographic result afterwards. There was an origin stenosis and a slightly longish segment stretch. A good result afterwards. 3 years later, a routine angiogram was performed, and you'll agree that this is an excellent result of stent implantation of the left pulmonary artery. But now, when he was virtually fully grown 4 years after that second study and 7 years after the initial stent implantation, what we see here is fairly severe intimal proliferation, and so that vessel is now much worse than it was originally when we implanted a stent. So neointimal proliferation is a potential problem, and in this patient we dealt with it by implanting a covered atrium stent in order to squeeze the intimal proliferation, and you see here now that the covered stent has squeezed the intimal proliferation into the other stent, and that is now a good sized vessel, but something we'll have to keep an eye on. Patients sometimes have multiple interventions, balloon septostomy, other interventions, and may finish up with bilateral femoral venous occlusions. And in a patient who might require a stent, for example, this one with a left pulmonary artery stenosis, we then have to approach this from a transhepatic approach. And you see here, from a transhepatic approach, a stent is being positioned across the left pulmonary artery. Here the balloon is being inflated, and then you'll see the angiographic result afterwards showing that the vessel is now nicely, widely patent. Bilateral branch stenoses, again related to stretch effect, require bilateral stents. And here's the angiographic result of stenting of both these vessels. But if both the branches are involved, then it's important to stent simultaneously rather than on separate sittings. The point I made about premounted stents earlier was the size that the stents can go up to. Here is a premounted Genesis stent in the left pulmonary artery, which is one of these 5 millimeter diameters. Ultimately, this can only go up to about 8 millimeters at most, maybe 9 if you stretch it, but then after that it will have to break and have another stent put in or require surgery. Sorry. And then that patient also, as you noticed, had a right pulmonary artery stenosis, which required stenting as well. This right clip is not working, I think. Oh, yeah. So here's the angiographic result of right pulmonary artery stent as well. This stent is fine. It will be dilatable up to adult size, but this stent is a small diameter one, which will have a problem. And then this is a patient in Athens that I helped with. This was a patient who was about 10 years old who had an arterial switch operation, had fairly severe left pulmonary artery stenosis, which was dilated with a balloon, and pretty much within a few days developed heart failure and big heart and continuous murmur. And what had happened was that there was erosion from the aorta into the left pulmonary artery origin. And so now this is an aortogram actually showing large flow into the pulmonary artery. So a fistula between the dilated aorta compressing on the left pulmonary artery, a little tear in the left pulmonary artery resulted in the fistula. And here's the, if this plays, this is the lateral projection. Again, it's an aortogram showing severe leak or fistula into the main pulmonary artery or left pulmonary artery origin here. So this patient was dealt with by putting in a covered stent. This is one of these covered Cheetham Platinum stents, covered CP stents. You see here the covered CP stent in position. And then the stent is inflated in order to try and block the origin of the fistula here. And then after deflating the balloon, an angiogram shows a good result of the pulmonary artery, but that's obviously not what we're interested in. It's more the aortogram, and you see here on the aortogram that now there is no flow into the pulmonary artery. The fistula is nicely covered with a stent, a covered stent, and this was the lateral projection of that as well. So a rare problem. And having said that it's rare, I've already come across 4 other patients around the world that have had this problem as well, and probably in this audience we'll suddenly find there's half a dozen others possibly. But it's surprising that it doesn't happen more often, especially when we're ballooning some of these lesions and possibly stenting some of these. Complications of stents in pulmonary arteries include death, rupture of the vessel, stent thrombosis, stent migration, balloon rupture, dissection of the vessel, aneurysm formation, stent fractures, and intimal proliferation. Some of those examples I've shown, others have not happened in post-arterial switch operation. The point I made about pre-mounted stents is that they have an advantage in that they're low profile and can be passed around the bends very easily. They're not going to slip off the balloon, but they have this limitation of expansion and should only be used in infants when there's a likelihood of further surgery being needed so that the surgeons can explant those stents. Other stents that I certainly have not used and not many people have used are these adjustable stents or the growth stents, where there are 2 halves to the stent which is linked by a bioabsorbable suture. Some experience has been gained in use of these stents by people like Peter Avert and Felix, but they're certainly at the moment not widely available. And then the other breakable stent that is being designed by Osipka, again, the principle sounds good, but at the moment they're all being studied and not widely available. Biodegradable stents. Again, in theory, there are lots of possibilities with these, but they've not been used in this sort of situation, post-arterial switch. The problem is their lateral strength, the radial strength, and also the biodegradability, the degradation rates. And so we have to keep an eye on what happens to the technology in the future. So to summarize, pulmonary arterial or secondary pulmonary stenosis is an infrequent complication after the arterial switch operation. Usually it occurs after the comp maneuver and is due to a stretch. Cutting balloons have no role in this. Balloon dilation may be effective in early infancy, and certainly high pressure ballooning is more effective than low pressure. Stents will give you more predictable results, but they need to be redilated to keep pace with growth of the patient. And some of these possible growth stents or breakable stents or biodegradable stents may become options for the future. So I thank you very much for your